Good morning, good afternoon, and good evening to our webinar participants. My name is Thomas Krüger, and I'm the product manager of the Babylog VN500, VN600, and VN800 at the Drägerwerk headquarters in Germany. I would like to welcome you to our international webinar conducted by Dr. Giovanni Vento from the Policlinico Universitario Agostino Gemelli in Rome. Dr. Vento is an academic neonatologist, and he is focusing in his research on neonatal respiratory physiology and mechanical ventilation. High-frequency oscillation is one of his major research topics. We are happy that he will share valuable information about his experiences and advice in clinical application of high-frequency oscillation, combining volume guarantee with high-frequency oscillation, as well as discussion of recruitment strategies with us. Now I would like to hand over to Dr. Vento for his presentation. So, Gianni, please.
Okay, thank you, Thomas. First of all, I would like to thank Dräger company for giving me the opportunity to speak with you about high-frequency oscillatory ventilation. And excuse me, okay. I work in NICU in Rome, and first of all, these represent the main characteristic of high-frequency oscillatory ventilation. This technique uses a very high frequency, 10-15 Hz, considering that 1 Hz represents 60 breaths per minute, and then the frequency usually used is between 600 and 900 breaths per minute. And as a consequence, all the machine using high frequency have to use an active expiration to avoid or to reduce the gas trapping. Another main characteristics of high-frequency oscillatory ventilation is the use of a very low tidal volume between 1.5 to 2.5 milliliter per kilo, and another important characteristic is the use of a very small peak-to-peak or delta pressure, because we have to be very careful when we see on the screen, on the display of the ventilator, the peak pressure, delta pressure of 20-25 centimeters of water. It not means that all these entire peak pressure are delivered to the more peripheral areas of the lung. And in effect, there is a specific damping attenuation of the pressure along the trachea and most importantly to the alveoli. This aspect will be discussed later. Which are the guiding principles of lung protective ventilation during high frequency? First of all is that the lung volume is maintained constantly above the functional residual capacity by the use of a constant distending pressure called mean airway pressure or continuous distending pressure. Another aspect is that high frequency uses very low tidal volume, smaller than anatomical dead space. Consider that anatomical dead space is approximately 2 milliliter per kilo of birth weight, and in this way, this type of ventilation prevents over-distension of more compliant lung units and improves ventilation perfusion mismatch. In theory, but only in theory, when we use a frequency, we can separate oxygenation and ventilation to manipulate them independently. But this is not completely true. But why we consider high frequency a protective ventilation? We know that ventilation means deformation, and this is called strain. In physiologic words, the strain represents the volume variation, delta V, over the starting volume. And we know from physiological studies that the ventilation-induced lung injury is dependent on the increase of this ratio. Higher delta V over starting volume, higher will be the ventilator-induced lung injury. And in effect, we have to distinguish the dynamic strain in red color that represent the stretching between 0 PEP and peak pressure, and the static strain that represent the deformation of the lung as a consequence of a peak positive and expiratory pressure used. In other words, from the physiological study, we know that we can reduce the ventilator-induced lung injury by minimizing the delta volume, the volume variation. And this is why high frequency could be considered more appropriately a protective ventilation with respect to the conventional ventilation, just because we use a lung volume that is maintained above functional residual capacity over the entire respiratory cycle, because we use a constant distenting pressure, always the same. And in other words, we increase the static strain. We use a mean airway pressure of 10, 12 centimeters of water. These represent the static strain, but in this way, the alveoli are constantly opened. And at the same time, we use the very small tidal volume. Do you remember 1.5, 2.5 milliliter per kilo? And these represent the dynamic strain in red color. So, in the opposite of this figure, when we use very high tidal volume and 0 PEEP, we undergo the lung to a very dramatic tidal volume, a very dramatic dynamic strain that is responsible for the ventilator-induced lung injury. On the opposite of this figure, we have the use of high frequency. You see that the entire volume is completely the same between this and this column, but the composition of the strain is completely different, because in this way, the static strain, the green color, is much higher respect to the dynamic strain consequence of the tidal volume. And this is why high frequency ventilation could be considered a very strategic protective lung ventilation, especially for the neonates. Regarding the mechanism of removal of CO2, we know that in conventional ventilation that are defined all the ventilation using less than 3 Hz, that is less than 180 breaths per minute, the minute ventilation is equal to the product of tidal volume times frequency. But in high frequency ventilation, is correct this equation to describe the CO2 removal? Some studies define that when we use high frequency oscillatory ventilation, is more correct to speak in terms of gas transport coefficient. And this CO2 is equal to the same factors, tidal volume and frequency. But you see that the tidal volume has a major effect than the frequency on the gas exchange. In effect, it means that very small tidal volume variation are responsible for a dramatic increase of CO2, and then we have a specific effect on CO2 elimination. In other words, this CO2 is the critical determinant of the efficiency of a gas mixing. The removal of CO2 in a frequency is approximately the equation frequency times 2 tidal volume squared, and this CO2 is an absolute value and depends on the tidal volume, and CO2 removal is most efficiently achieved by increasing the tidal volume. And this is why when we use a frequency and we have a patient with hypercapnia, it's sufficient to increase the tidal volume of 0.1, 0.2 to determine a significant effect on CO2 removal. In the last years, Manuel Sanchez Luna performed an experimental study on an animal model, and just because we recently introduced the high frequency plus volume guarantee, it means that the volume remains always the same, okay? And for this reason, when we increase the frequency by using high frequency plus volume guarantee, the increase of a frequency could have some effects on the dCO2. And this is why this is the suggested definition of dCO2 correct when we use high frequency plus volume guarantee. It means that not only the tidal volume, but also the frequency could have an effect on the CO2 removal. But this is not yet completely approved, this equation of motion. Before we speak about the pressure damping during a frequency, this is a very interesting figure. You can see on the top the example of a compliant lung. In the black line represents the pressure curve of during conventional ventilation. The blue lines represent the peak pressure during high frequency ventilation. And you see that when we use a conventional ventilation, the peak pressure, about 25 centimeters of water, is equally transmitted to the periphery. The only change is the shape of the curve, because of course is more triangular at alveolar compartment respect to the square shape at the airway opening. But the completely different is the pressure damping, and you see that at alveolar level the pressure is very, very small. It depends that during a frequency, the very short inspiratory time are insufficient to fully transmit the complete pressure waveform. And this is why we have a progressive damping of the pressure waveform from airway opening to the alveolar compartment. And this is a very important aspect to consider when we use high frequency. And the B part of the figure represents what happens in case of a less compliant lung, for example, a baby with RDS before surfactant administration. You see that also in both conventional black line and high frequency blue line, the peak pressure needed to deliver the same tidal volume will be higher because the lung is less compliant. But at the same time, we have a progressive damping of the pressure during the passage from the airway to the large airways and to the alveoli. But you see that the damping will be reduced because, in other words, when there is a less compliant lung, the pressure will not be attenuated completely, because the transfer of the energy, kinetic energy of the pressure, will not be responsible for the simultaneous lung volume expansion, because the lung is less compliant, and then there will be a lower attenuation of the pressure, also by using high frequency. You see that the level of peak delta pressure in a compliant lung is very, very small, a little higher in case of a less compliant lung. In other words, the damping is dependent on the compliance and the frequency. You see that higher the compliance and lower will be the percentage of the transmission of the airway opening pressure. Okay, and another important aspect is that higher the frequency and lower will be the percentage of the transmission. Why this? Because when we use very high frequency, the absolute time of inspiration time will be reduced, okay? And then there is no sufficient time to transmit completely the pressure to the more peripheral airways. In the conclusion, the pressure amplitude transmission decrease with increasing compliance, increasing frequency, but also by decreasing the inner diameter of endotracheal tube. Because when we use a very small endotracheal tube, the resistance will be increased, and then higher resistance means that there is an opposition to the full transmission of the pressure from the airway opening to the alveoli. And this is why it's important when we use a frequency ventilation in preterm neonates to use the bigger endotracheal tube, because it's very, very difficult to apply a frequency when we use 2.0 endotracheal tube diameter. It's not impossible, but of course this represents a very resistive system. In general, when we have to use high frequency, it's important also in neonatal physiology to distinguish between restrictive respiratory disease, example of homogeneous lung disease such as RDS, pulmonary hypoplasia, or pneumonia, and an opposite chapter is represented by the obstructive respiratory disease of the newborn, in which we have inhomogeneous lung disease. Example of these are bronchopulmonary dysplasia, meconium aspiration syndrome, air leak, or also pulmonary hemorrhage. But why we show this slide? Because we have to distinguish which are the most affected respiratory mechanics. In the first category, in the restrictive respiratory disease, we have a reduction of compliance. On the opposite, in the obstructive respiratory disease, the most important mechanical property of the lung will be an increase of the resistance. It means very different time constant. You know that the time constant is the product of the compliance times the resistance. So, according to the specific pathology of the lung, we will use specific frequency and specific respiratory setting. In our hospital, since 2000-2005, we use elective high-frequency ventilation in these categories of the babies. First of all the extremely low gestational age newborns needing mechanical ventilation, even if in the last decades there is an increasing number of the babies, also the extremely low gestational age, not intubated into the delivery room, but in some cases we have to intubate the babies, and in this baby we use high frequency electively, and also in the extremely low birth weight infants that represent the most vulnerable infants. Also, we use elective high frequency ventilation in case of pulmonary hypoplasia, congenital diaphragmatic hernia, in case of air leak, and hydrops fetalis with pleural effusion, also in case of pulmonary hypertension of the neonates and meconium aspiration syndrome. On the other side, we use high frequency ventilation as a rescue therapy in the newborns with the gestational age more than 27 weeks, requiring in conventional ventilation a peak pressure equal to or more than 25 centimeters of water, or an FiO2 more than 40% after surfactant. We know, of course, that high frequency have some limits and pitfalls, in particular severe hypotension with low cardiac output. And in effect, we know the relationship between changes in lung volume and pulmonary vascular resistance. This is a very clear figure that shows us the total pulmonary vascular resistance are increased in both the extreme of lung volume. The pulmonary vascular resistance are high also when the residual volume is very low, that is when the lung is at electasics. But at the same time, we know that if we hyper-expanded the lungs, we can have at the same time an increase in total pulmonary vascular resistance because we have a compression of the alveolar vessels. And then we have to stay in the middle. And this is why in this review is stressed the importance in terms of a cardiorespiratory interaction that the clinician should titrate the mean airway pressure to optimize the balance between mean lung volume, that is arterial oxygenation, and ventricular function, that is global cardiac output, to minimize pulmonary vascular resistance and routinely monitor cardiorespiratory parameters closely. So, in terms of main parameters to be used during a frequency ventilation, one parameter is the delta P. When we applied a delta P of 15 centimeters of water, it means that we applied 7.5 centimeters above the mean airway pressure and 7 centimeters less under the mean airway pressure. Okay, but this is true only when we use a expiration to expiration ratio of 1:1. That is the duration of inspiratory phase and expiratory phase are perfectly the same. The clinician sets the pressure amplitude on the ventilator as the principal modifiable parameter controlling oscillatory volume, which is ultimately the key determinant of CO2 removal. Do you remember that the VCO2 is the product of the tidal volume times the frequency? So, to increase the ventilation in case of hypercapnia, or to reduce ventilation in case of hypocapnia, we have to act on the tidal volume. And to act on the tidal volume, we have to modify the delta P pressure, okay? Because above approximately 3-5 Hertz, oscillatory volume influence the TCO2. This is very, very important to know. But this is an elegant work by Miedema and Van Kamp group that demonstrated has during a recruitment maneuver in a frequency oscillatory ventilation, there is a dramatic changes in tidal volume and also in PaCO2, even if no changes in the delta P were applied during the procedure. You know that this is the step-by-step increase in mean airway pressure during the recruitment maneuver, and we see that there is an increase in oscillatory volume. In this study, the authors used respiratory inductive plethysmography to measure the oscillatory volume during the recruitment maneuver, and also we have a concomitant decrease of PCO2. But this is why it happens. It happens because changes in tidal volume occurs during the recruitment maneuver secondary to the increase in respiratory compliance, and that is responsible for the marked change in PaCO2 if no adjustment of delta P is used. And this is why oxygenation and ventilation also during a frequency ventilation are not always uncoupled. This is very important. And in effect, also in our work, published some years ago, in which we measure all these parameters, including respiratory inductive plethysmography to measure the lung volume modification secondary to a recruitment maneuver, we observed that at the end of the recruitment maneuver, even if we did not change delta pressure, in this work we don't use high frequency plus volume guarantee, but only high frequency, we observed a significant increase in tidal volume. That is the same results by Miedema et al. And in effect, it depends on the increases of compliance. And at the same time, only a small decrease of PaCO2 we observed by monitoring transcutaneous PCO2. This to underline the importance of the changes in mechanical properties of the lung, secondary, for example, to a recruitment maneuver or secondary to surfactant administration, that it's important to be very careful because the tidal volume could be dramatically changed secondary to the change in mechanical properties of the lungs, that is, in the increase of the compliance. And this is why it's very, very useful to apply the volume guarantee also during high frequency. In conventional ventilation, the use of volume target ventilation is very popular, and the machine will automatically modify the pressure, the peak pressure, to deliver the same tidal volume, also independently of the changes of the mechanical properties of the lung. On the same way, also when we use a frequency, it's very, very important to apply volume guarantee modality. And in this modality, the machine, the WAN 500, 600, 800, will deliver the constant tidal volume by modifying the amplitude regulated. In our observational study, we compared 11 patients treated by high frequency without volume guarantee and plus volume guarantee, extremely low gestational age newborns suffering from RDS, and we evaluated the changes of tidal volume in high frequency, delta pressure, and PCO2. And at the start of the study, no significant difference exists between the two groups, high frequency and high frequency plus volume guarantee. Pre-surfactant, significant difference between the two groups in terms of the tidal volume. Okay, the tidal volume is less in the volume guarantee modality, about 1.6 milliliter. But, and this is the very important results, is that after 1 hour of surfactant administration, we have a dramatical difference between the tidal volume, because in the group of high frequency without volume guarantee, the tidal volume significantly increases respect to the pre-surfactant time. On the opposite side, when we use high frequency plus volume guarantee, the tidal volume is perfectly the same pre and post surfactant. And you see that the delta pressure applied in high frequency plus volume guarantee is dramatically reduced, just because the machine delivers the same tidal volume, and as a consequence of the improved compliance of the lung, the delta pressure needed to deliver the same tidal volume, 1.6, will be automatically reduced. And as the last observation, the PCO2 in the group of high frequency plus volume guarantee remain practically the same. Respect to the babies treated with high frequency without volume guarantee, in which the PCO2 significantly reduced after the surfactant. And this is a Pearson correlation showing a very good correlation between tidal volume and PCO2. Higher tidal volume, 2.5, lower PCO2. And this is what we have absolutely to avoid. This is the value of the baby treated with high frequency without volume guarantee after surfactant. Okay, we know that it's very, very important to stay in these closed windows to avoid the hypocapnia and the risk of periventricular hypomalacia and so on. So this is another important message. When we have to reduce the PCO2 in case of hypercapnia, or when we have to increase PCO2 in case of hypocapnia, we have to be very careful. We have to not produce a dramatic increase or decrease of PCO2. It's important to increase or decrease the tidal volume of no more than 0.1, 0.2 milliliter per kilo, step by step, because the PCO2 had to increase or decrease very slowly to avoid the very too rapid modification of PCO2 that are very careful, a very dramatic effect on the cerebral circulation. Another important parameter we have to choose when we start high frequency ventilation is the frequency, that is the number of oscillation per minute. In this figure, we saw the effect of time constant on the corner frequency of the lung. The corner frequency of the lung is the frequency above which there is a loss of energy. So we have to stay also within the corner frequency. And the time constant is the product of resistance and compliance. As the time constant shortens, the corner frequency of the respiratory system increases. For example, a preterm infant of 600 grams with a compliance of 0.1 milliliter centimeter is a severe RDS, and a resistance of 100 centimeter liter per second has a time constant of 10 milliseconds, and in this case, a corner frequency of 15.9 Hz. And this is important for us because when we use high frequency for extremely low gestational age newborns, we can start with 15 Hz because this is appropriate for a very small preterm infants. And in this very useful figure by Jane Pilov, these are the frequency recommended to start in terms of lung pathology, because the user frequency should be adjusted according to the underlying mechanical properties of the airways and the lung. In general, lower frequency, 7 to 10, in high resistance and or high compliance lung, for example, meconium aspiration syndrome, term lung disease, in which we have a very high resistance, small compliance, but the time constant will be increased. And then we have to use a small frequency just because we have to increase the duration of inspiratory time, because the time constant of that lung is high. On the opposite, higher frequency will be used in low compliant lung with the normal resistance because we have a very short time constant. Do you remember the example we had just a few minutes ago? A 600 grams preterm baby with severe RDS, very, very small compliance, normal resistance, time constant 10 milliseconds, then is appropriate to use 15 Hz for these babies, okay? Another important aspect is the inspiration to expiration ratio. And this determines the proportion of the time spent when the oscillatory pressure is above during inspiration or below during expiration phase, the mean airway pressure, resulting in similar fluctuation of positive and negative flow. The peak and trough of the oscillatory pressure waveform are similarly distant in opposite direction from the mean airway pressure when inspiratory and expiratory cycle duration are of equal value. That is when we use inspiration to expiration ratio of 1:1. However, equidistance of the peak through from the mean does not apply when we use inspiration to expiration ratio other than 1:1. And this is clearly shown in this figure. When we use 1:1, the area under the curve in A inspiration and B expiration are perfectly the same. When we use 1:2 ratio, of course, it means that the inspiration is shorter in duration but higher in peak pressure, in the opposite of the expiration phase, in which we have a duration about double and a thaw apparently the half, just because the area under the curve should be always the same, okay? But an important concept that Jane Pilov says is that the mean intrapulmonary pressure is the effective pressure distending the lungs, and it cannot be measured directly. That is, when we increase the mean airway pressure and we So on the display of the ventilator, 12 of a mean airway pressure, 14 and so on, we have to be sure that the same level of a mean airway pressure will be measured at alveolar compartment. So the mean airway intrapulmonary pressure is closest to the set mean airway pressure when we use inspiration to expiration ratio of 1:1. When we use a different ratio, 1:2 or 1:3, it has been demonstrated in the animal models that mean intrapulmonary pressure will be lower than the set mean airway pressure. So, in conclusion, we have to know that when we use a frequency strategy and we have to improve oxygenation, oxygenation depends on these two principal parameters, mean airway pressure and FiO2. The ventilation, that is the CO2 removal, depends on the tidal volume, okay? Higher tidal volume, higher ventilation. Do you remember the equation, minus ventilation, dCO2 in high frequency is the product of tidal volume squared times the frequency. So the main determinant of the ventilation will be the tidal volume. And then we have to modify the tidal volume. How we can modify the tidal volume? By applying the delta pressure. And we know that the delta P will be dependent on the duration of absolute inspiratory time, that in turn depend on the respiratory rate and inspiration to expiration ratio. Okay? This is the philosophy, this is the physiology underlying the use of high frequency. And we have always to keep in mind this figure, because we have to reasoning when we modify the setting parameter. But at the same time, we know that tidal volume falls as frequency increase always. And this is why in the past we reasoned that when we use a frequency, be careful, because when we increase the frequency, the CO2 will be increased. Why this? Because when we increase the frequency, we reduce the duration of inspiratory time. And this is responsible for lower delta P and then lower tidal volume. But recently, we always use a volume guarantee modality, and then the machine will modify automatically the delta P, delta pressure, to deliver the same tidal volume. So these sentences, that is, tidal volume falls as frequency increase, is not true when we use high frequency plus volume guarantee. And this is why also the inspiration to expiration ratio of 1:2 that was always suggested when we use sensormedics is not completely true at the present when we use these hybrid ventilators, including WEN 500, 600, and 800, in which we can use safely the 1:1 inspiratory to expiration ratio. Okay, this is what we use in our center, and we don't have any side effects. And it's a pleasure for me to share with you our protocol when we use in our unit to apply the optimum lung volume strategy during a frequency ventilation in the babies treated with elective high frequency. We start with the mean airway pressure of 8-10 centimeters of water, a respiratory rate of 15 Hz. We use always volume guarantee by setting 1.5-1.7 milliliter per kilo, always using 1:1 inspiratory to expiratory ratio, and by using FiO2 to achieve target SpO2 values. But it's very, very important verify as soon as possible the goodness of the tidal volume chosen by transcutaneous CO2 monitoring and or blood gas analysis, because of course we have to be sure that the volume guarantee used in this baby is appropriate to guarantee the target PCO2 between 45 and 55 millimeters of mercury. In general, 1.5 is a good starting tidal volume. We don't have cases of hypocapnia in most of the babies, so we recommend to start with 1.5. And at the same time, our strategy is to use a recruitment strategy, and in some cases we can set a new volume guarantee if necessary on the basis of the CO2 monitoring. And always our strategy is to use the lowest level of linear pressure, guaranteeing optimal oxygenation with the target FiO2 of 25%. Then we continue to monitor transcutaneous CO2 and look at tidal volume set and delivered, and also under delta P delivered and also under dCO2. Another important aspect is the weaning from high frequency. As Jim Pilov suggested, weaning from high frequency directly to a non-invasive mode of respiratory support is possible and often the preferred mode. This is the suggested pre-extubation parameters in high frequency for our extremely low gestational age newborns during the first week of life. Of course, when an extubation attempt is made after 2-3 weeks of time, we tolerate mean airway pressure, higher values of mean airway pressure, such as 8.5 centimeters of water before attempting an extubation. And this is our experience. We published the results of extubation directly from high frequency oscillatory ventilation in extremely low birth weight infants, and we obtained about 90% success of extubation rate, defined as more than 1 week of non-invasive respiratory support post-extubation. And this is why, while in the past and also now some centers prefer to extubate the baby with a weaning process from a frequency to conventional ventilation, we believe that is not recommended to start on conventional ventilation before extubation, because we can directly weaning from a frequency to a non-invasive mode of respiratory support. The last part of my presentation will describe the importance of a lung recruitment maneuver that can be performed with high-frequency oscillatory ventilation. First of all, just to share with you the recommendation of the European Consensus Guideline regarding the approach and the strategy to be used in the delivery room. The European Guideline suggests that intubation should be reserved for babies not responding to positive pressure ventilation by face mask or nasal trunks. And more recently, the American Academy of Pediatrics suggested that the most important priority for newborn survival is the establishment of adequate lung inflation and ventilation after birth. That is, we have to favor the achievement of an adequate functional residual capacity since the delivery room resuscitation. And this is why it's very important to apply a nasal positive CPAP to increase and to promote the functional residual capacity to be obtained. In other words, we have to start to recruit the lungs since immediately after the birth. But some difficulties exist because which is the best way for surfactant delivery is not completely well defined. For this field, the European Consensus Guideline recommends the use of less invasive surfactant administration because it's defined as the preferred mode of surfactant administration for spontaneously breathing babies on CPAP. But the level of evidence is not too high, is a B2 evidence. The position statement of a Canadian Pediatric Society is not so definitive conclusion because they describe Ensure as the preferred mode the widely accepted mode in clinical practice, and defined the less invasive surfactant administration together with laryngeal mask or nebulization as a newer method of non-invasive surfactant administration. Okay, but really, when we see also the meta-analysis that describe that among preterm infants, the use of a less invasive surfactant administration was associated with the lowest likelihood of the composite outcome of death of BPD at 36 weeks of postmenstrual age, the authors concluded that these findings were limited by the overall low quality of evidence and lack of robust in higher quality trials. And in effect, if you see the results, you can verify that the comparison between less invasive surfactant administration and another standard approach that is Ensure is only evaluated in 3 trials, not very recent trials, and also in babies not very small, not extremely low, but all the babies had a mean gestational age of 28, 29. Just to see to you that the evidence of using a less invasive surfactant administration in extremely preterm neonates with gestational age less than 28 weeks is not completely true. And in effect, this is another way to demonstrate the same effect. When we look at the composite outcome of that of BPD, these are the only 3 trials comparing less invasive with Ensure method. So I believe our group 3 years ago designed this study in Ensure to evaluate the efficacy of a recruitment maneuver performed just before surfactant administration, followed by rapid extubation. The result of this trial has been published recently on the Lancet Respiratory Medicine, and we randomized babies of 24 to 27 weeks of gestational age, not intubated in the delivery room and reaching failure criteria of CPAP within the first 24 hours of life. And they were randomized to receive Ensure or classical Ensure. Our primary outcome was the need for mechanical ventilation in the first 72 hours of life. And we performed analysis in terms of intention to treat and per protocol. This is the flow diagram of our study, 218 patients randomly assigned, and the infants were ineligible if they had severe birth asphyxia or they were intubated in the delivery room. Just to describe what babies we randomized. During the study period, in the 35 NICUs in Italy participating at the trial, 1,156 preterm babies of 24, 27 weeks were born during the study period at risk for RDS. Of these 600, more than half patients, represent the bad infants. This is the methods of describing the babies in the delivery room suggested by Alan Job several years ago. The bad infants are the babies who required immediate intubation in the delivery room. But at the same time, we have 237 infants that were managed in the delivery room with the nasal CPAP, and they never need of surfactant administration. They never need mechanical ventilation. They represent the good infants in which the early application of adequate level of CPAP in our study was 6-7 centimeters of water, represent the bridge to resolve the respiratory insufficiency, and these babies were successfully treated with only CPAP. The last category of the babies as the so-called marginal infants. that is, babies not intubated in the delivery room, managed with the CPAP, but reaching CPAP failure and needing surfactant. These babies were randomized to receive surfactant by insure method or enrichure method. These are the baseline characteristics. The babies were 26 weeks of mean gestational age, 800 grams of mean birth weight. They were equally managed in the delivery room with about 6 centimeters of water, 30% of FiO2. CPAP before surfactant administration is 6 centimeters of water, and the FiO2 at the moment of CPAP failure was pretty the same in the two groups, 0.42 FiO2 requirement. These represent the Hfo Recruitment Maneuver, starting with 8 centimeters of water. We recruit the lung, arriving to FiO2 of 25%. And at this point, we started the recruitment, and this was called the opening pressure. After this, we started to recruit the lung by reducing the mean airway pressure of 1 to 2 centimeters of water every 2-3 minutes until oxygenation deteriorates. These represent the closing pressure, and at this point, we recruit the lung once more with no map opening for 2 minutes again, and set the mean airway pressure 2 centimeters of water above the closing pressure for at least 3 minutes. These represent our optimal pressure, and at this point, and only at this point, after the recruitment maneuver, we give surfactant to the babies. This represents the recruitment maneuver we applied in our infants randomized to the enrichure arm. The duration of the recruitment maneuver has been the 30 minutes, ranging from 20 to 45 minutes. And this is why the surfactant administration was happened significantly later in the babies, 1 hour later. And these represent the mean values of opening pressure, closing pressure, and optimal pressure. It means that we deliver the surfactant at the babies who received a mean airway pressure of about 30 centimeters of water. As a consequence, we dramatically reduce the FiO2, and you see that there is a significant difference in terms of FiO2 required by the babies receiving insure procedure respect to the babies receiving enrichure, because we have opened the lung, and in effect we saw that during the recruitment maneuver we obtained the same FiO2 at a lower level of mean airway pressure, because we of course had the phenomenon of the hysteresis, the pulmonary hysteresis. That is, when we opened the lung gained volume even if we reduced the mean airway pressure. These are the list of ventilators used in our multi-center trial. Most of the centers used WEN 500, and only 2 patients received the recruitment maneuver by sensor medics. All the babies were extubated at the end of recruitment maneuver, and the pre-specified parameters to start mechanical ventilation that represent our main primary outcome was a need of FiO2 more than 40% or a respiratory acidosis defined as a pH less than 7.2 or apnea. After the surfactant, all the babies received the non-invasive respiratory support. Because this is not a blinded study, we realized this analysis to be sure that no bias effect will be present in the trial. And you can see that all the three main non-invasive respiratory support strategies, CPAP, BiPAP, and nasal intermittent positive pressure ventilation, were equally distributed between the two groups. So the effect of needed of mechanical ventilation is not reasonably dependent on the type of non-invasive respiratory support. Regarding the results, our primary outcome was reached because you see that the babies receiving Hfo needed mechanical ventilation during the first 72 hours of life in a significantly lower percentage respect to the babies receiving Hfo approach. And also in per protocol analysis, the effect is also more evident, also in terms of the mortality. And most importantly, the side effects, pneumothorax or intraventricular hemorrhage worse than second degree, were equally distributed, also in lower percentage in the babies receiving Hfo. And in this, as a conclusion, lung recruitment maneuver before early rescue surfactant administration in extremely preterm neonates with RDS appears safe and reduces the need for mechanical ventilation in the first 72 hours of life. To our knowledge, this study is the first randomized clinical trial reporting this effect in human preterm infants. Just to describe that the commentary by Neil Feiner and Anup Katiria was that, therefore, we believe that the next logical step would be the comparison of Hfo with less invasive surfactant administration in larger study powered for such important outcomes. In the scientific community, there was some interest after our publication. There were some letters to the editor, our reply, and this is the new trial we are designing, aiming to compare the Hfo with the less invasive surfactant administration respect to the primary trial. In this new trial, we will use high frequency ventilation plus volume guarantee during the recruitment maneuver, and the outcome will be a more robust outcome, the composite of that or VPD. And just to finish, our experience in our center is with the VOAF 500 ventilator, but you have to know that there are available also more modern Babylog VOAF 600 and VOAF 800, but it's important to know that the algorithm and the mechanical property of the ventilator are pretty the same. The quality improvement has been transferred in terms of the display, but if you use VOAF 500 and if you use VOAF 800 or 600, all the parameters, all the setting we have suggested, I have suggested, is the same by using all three types of ventilator. And thank you for your attention.
Thank you very much for your presentation, Dr. Vento. I think the last question or the last slide you showed related the planned study comparison of Hfo and LISA will be very interesting to see what the results are of the study. I think many people would be very interested about this. So we now will start the question and answer session a little late, but however, I hope that you can spend some more minutes. If you haven't asked already, use the question via the chat function or the question function of your webinar toolbox on the right-hand side. And we, in fact, have already a few questions. And so I will read this now for you. I think even if you explained this quite well, there's one question. What is your lung recruitment strategy with high frequency plus volume guarantee for bad babies with FiO2 of 100% requirement?
Okay. Is a very interesting question. I thank you for this, because I described the recruitment maneuver, but we have to know that not all the lungs are well recruitable. For example, when we have an hypoplastic lung, such as the lung of the baby born after very early premature rupture of membrane, in which we have a very, very low compliant lung, we can try to recruit the lung, but it will be very, very difficult, if not impossible, to reach the target FiO2 of 25%. In general, we have always to try to recruit the lung, also in the very low compliant lung. And we have to stop to increase the mean airway pressure if no concomitant improvement in saturation and then in reducing FiO2 will be shown. So the importance of the recruitment maneuver is that we can use in all the different lung, but also knowing that not all the lungs are the same. The recruitment maneuver is perfectly is perfect to adopt when we have a simple RDS. But if you have the component of pulmonary hypertension or the component of pulmonary hypoplasia, such as the baby who need 100% of oxygen, you can try to increase the mean airway pressure and to stopping, even if the FiO2 no longer decrease under 60%, 80%. But anyway, you have increased a gain in volume that will favor the also your, for example, surfactant administration and so on. But this is I hope to have replied to the question.
Yeah, thank you, Gianni. There's another question which relates to phase 3 of your recruitment maneuver. In phase 3, do you go directly to the known mean airway pressure, or do you increase mean airway pressure slowly to the same value?
Excuse me, when I find the opening pressure, then we reduce the mean airway pressure until closing pressure. From this point, we reopened the lung by moving directly from the closing pressure to the opening pressure, not step by step, because the recruitment maneuver is useful for know which is the opening pressure for that lung. Then when I arrive to 16, 18, okay, this is my opening pressure. I will start to reduce the mean airway pressure until oxygenation deteriorates. And this is another important point. In some babies, when we reduce the mean airway pressure, in some cases we have a dramatical SpO2 reduction, and then we have to increase FiO2. But in most of patients, to define the closing pressure, the closing pressure will be the level of mean airway pressure at which the SpO2 values drop from 90 to 93% to 88, 89. So it's sufficient 3-4 points of less saturation to define the closing pressure. Okay, and when I found the closing pressure, for example, from 18 opening pressure to 13 closing pressure, from 13 I can arrive directly to 18, stay for 2-3 minutes until oxygenation improves, and then I will set the mean airway pressure 2 centimeters above the closing pressure, in this case from 13 to 15. And at this point, I will give surfactant.
Okay, thank you. Gianni, there's right at this point there's a question: how are you introducing surfactant on mean airway pressure of 12 as opening the tube will losing all the pressure introduced? So it's a practical aspect how you apply then the surfactant.
Yes, a very important question, but in effect, we recommend to use a closed system to give surfactant. And also in our study, published on the Lancet Respiratory Medicine, we use always the same closed circuit to give surfactant to avoid the loss of volume, both during high frequency, but also in the babies receiving Hfo method that we ventilated with the TPs to give most of protective ventilation, the peak pressure no more than 20, 22, a PEEP, positive expiratory pressure of 5 to 6, but in all the arms, in both arms of the babies, we give surfactant with a closed circuit to avoid loss of pressure and consequently loss of volume. So this is an important question. I think that in our center has become a standard of care to use this closed system to give surfactant.
Thank you.
As very simple to use.
Yeah. Thank you, Gianni. There's another question also as well, very practical nature. Hello, how do you perform InREC in the delivery room?
We never performed InREC in the delivery room. The last Cochrane suggested that the prophylactic surfactant is not yet recommended because it's accompanied to an increased risk of mortality and BPD. The only advantage of performing a prophylactic surfactant in the delivery room was in a previous era when steroids prenatal administration was very low, and when early CPAP in the delivery room was not standard of care. But evidence suggested that when we use and when we apply very early nasal CPAP in the delivery room to all the extremely low gestational age, to start to promote the functional residual capacity, and when we have a good steroids prenatal administration, we have the time to stabilize the baby in the delivery room, to take the baby from the delivery room to bring the baby in the NICU. And in effect, also in our study, you see that a lot of babies were managed only with the nasal CPAP without any surfactant administration. So in our center, only very sporadically we give surfactant in the delivery room, but in a baby with severe pulmonary hypoplasia who does not respond to intubation, recruitment, FiO2 of 100%, but is very, very, very rare. I do not recommend to use surfactant in the delivery room. So and this is why we suggest to stabilize the baby in the delivery room, bring the baby NICU, and to continue non-invasive respiratory support. Just in case of surfactant administration, in our center and in other centers in Italy, after the end of the randomized clinical trial, we continue to use InREC because it has been shown to be advantageous for our preterm babies. And just another important question, we can perform a recruitment maneuver also in older babies. In effect, another study we have presented, we introduced our study design in the clinicaltrial.gov, the use of a surfactant, a late surfactant administration preceded by a recruitment maneuver to demonstrate a possible superiority of this, because you know that there are two studies evaluating the efficacy of late surfactant administration in babies in evolving BPD after 10 days of mechanical ventilation, but no studies demonstrated an efficacy of surfactant. we try to evaluate the efficacy of a surfactant, late surfactant after 7-10 days of mechanical ventilation, preceded by recruitment maneuver.
Thank you, Gianni. One last question, because we are running out of time a little bit, but there's one question. Do you use high-frequency psi function? And if so, can it be considered to reduce the need for performing recruitment maneuvers repeatedly?
Excuse me, do you use
high-frequency psi function? So this intermediate IMV breath.
We have not very much experience. We prefer to re-recruit the lung in case of a baby who need prolonged mechanical ventilation. We have some cases in which we are not able to extubate the babies, and in these cases, after stabilizing the lungs, in some cases we observe an increase in FiO2 that could be dependent on a ventilator-associated pneumonia or a concomitant sepsis that can deteriorate the lung function. And in this case, we use to re-recruit the lung to obtain the lowest FiO2 instead of intermittent conventional mechanical ventilation. I believe that in our mind we can change our philosophy, because also in our center some physicians prefer to change from a frequency to conventional because it is easier, is simple. But in my opinion, it is not completely true, because the risk of conventional ventilation, even if targeted conventional ventilation in very immature lungs, the risk of a ventilator-induced lung injury is very high. So we do not use psychs, but we prefer to re-recruit the lung also always in a frequency in case of FiO2 increase or pulmonary deterioration.
Thank you very much, Gianni, for answering also this question. There are much more of questions, many related to this recruitment maneuver. So I think we could really organize a webinar just for only this maneuver and all the aspects of this and how to handle this, including the weaning then. However, we have to close now our online question and answer session. We have asked Dr. Vento that also the remaining questions will be answered by him in a written way. So we will send later then the answers from Dr. Vento to all of you, so you can read his answers to all of your questions. Additionally, you will get a link for the recording. So this will be available on our website over the next days. So you will receive an email from us with the link to the online neonatal ventilation platform, where we offer educational content as well, and where we also inform about upcoming events like this webinar today. So thank you very much for logging into our webinar today, and thank you, Dr. Vento, for conducting this webinar with us. We would like to be very happy if we receive your feedback for today's webinar as well. So goodbye and have a nice day.
Bye-bye. Thank you.
Thank you.